We have a quorum, and I think I got most everybody done, so we're ready.
Okay, great. So thank you, everybody, for joining us for EMCC this morning. We have a bit of an unusual circumstance in that we received a late notification from both the chair of the committee and the vice chair for the committee that they will be unable to attend today's meeting. Given that circumstance, we need to select a chair pro tem for the day to fill in. So we will open up the floor for nominations for a chair for the day to fill in their stead.
I move past Chair Tina Nieto, take it over. Sorry, Chief, for this meeting.
I second that.
So I appreciate that. However, as we're going to discuss later, a couple of our members haven't received board approval yet. So Luz, you're one of those. We still need your letter of recommendation. So we do still need a second.
Steve, it's Carla. Can I second?
Carla, you can second. You've been appointed by the board.
Okay, I'll second.
Great. So we have a first and a second. Steve, can we have a roll call vote on that?
Okay, roll call. Will Hiller.
Aye.
Tina Nieto.
Aye.
Sam Klemick.
Aye.
Jim Lineborg is absent. Terry Robbins.
Present.
Jody Schaefer.
Aye.
Is that Jody?
Aye.
Oh, perfect. Thank you. Let's see, then Dr. Greenson.
Aye.
Perfect. Yeah. Carla Spencer,
Aye.
John Anthony.
Aye.
Perfect. Let me just go through here. All right, we have everybody who can vote done so.
And Tina, my apologies. Are you willing to serve as the?
Yeah, hold on one second. I'm just bringing up, I had the wrong agenda up. I had the earlier one, so let me just bring it up real quick.
Thank you, Tina.
All right, I got it. So this meeting, we have a quorum, so we'll bring this meeting to order. And we'll call for introductions. So there's new staff introductions, I guess. We have two people. Oh, before we do that, are there any guests that would like to introduce themselves?
If I could, we start with the alternate members, Mike Gesslinger.
Hi, everybody. Mike Esslinger from AMR's here.
Perfect. Roger Reinhardt.
Roger Reinhardt, Battalion Chief, CAL FIRE EMS.
Cheryl Getz. Joe Cafaro. Keith
Hello,
Boyd.
Joe Kafar from the Hospital Council. Thank you.
Oh, thank you. Keith Boyd.
Keith Boyd, alternate County Chief of Police.
Andy Smith. Ex officio, Teresa Rios. Gary Millay. Leanne Migoski.
Good morning, Leanne Migoski's here.
Thank you very much. And now, if those who are guests would like to identify themselves.
Good morning, Dave Gilladucci with Santa Cruz and San Benito EMS agencies.
Casey Grover and Reb Close with CHOMP and the Monterey County Prescribed Safe Initiative.
Bruce.
Gene Hearn with California Bridge.
Sandra Flores, AMR Communications.
And Hitchcock, AMR CES.
Rachel Nealand, AMR CES.
Justin Reyes, Division Chief of EMS for Monterey County Regional Fire.
Carlos Vega, Division Chief, Marina Fire Department.
Is that it? Are there any other guests that would like to introduce themselves at this time?
Noah Hawthorne Memorial Year.
Okay, Steve, I think that's it.
Yes, thank you.
All right, moving on now to EMS agency staff, new staff introductions. Let's start with Jesse Allard.
Hi, thanks, Chief, and sorry for those of you on Mac who have to hear the same spiel again. But my name is Jesse Allard. I'm currently living in Marina with my family. I'm kind of a longtime paramedic, 20 plus years or so, and I've had the privilege of working with 2 different EMS agencies, Napa and Contra Costa, in different capacities. So I bring what I feel is a good amount of knowledge and background, but I'm also really eager to learn on the system here, learn with and from all of you, and be a resource along the way. So thank you so much, Chief.
Thank you, Jesse, and welcome. Next is Blake Anderson.
Hello, everyone. Blake Anderson. I'm from the Sacramento area. I just got out of the field working for American Medical Response for a little over 7 years and been an EMT for almost 10 years. During my time at American Medical Response, I was a field training officer. I was a CISM support, strike team member, and I was chief union steward out there. New to the Monterey area. I'm looking forward to meeting all of you and collaborating with every single one of you.
Blake, again, welcome and thank you. Moving on now to public comment. Any member of the public can have up to 3 minutes to talk about any issue not on the agenda. Is anybody in the public, would they like to speak on any issue not on the agenda? I'm opening the floor. Seeing no hands or any verbal comments, we'll move on now to the approval of past EMCC meeting minutes to include May 11th, June 8th, July 6th, August 3rd, and August 30th. They should have all been either sent or attached to this agenda. Can I get a motion to approve those 5 dates?
This is the time I move approval of all 5 minutes subject to comment.
Second that approval.
So Harry moved and Jody seconded. With that, can we get a roll call vote?
Roll call coming up. Will Hiller.
Aye.
Tina Nieto.
Aye.
Sam Klemick.
Aye.
Jim Landborg. I'm sorry, he's absent. Harry Robbins.
Aye.
Jody Schaefer.
Aye.
Nick Greenson.
Aye.
Carla Spencer.
Aye.
John Anthony.
Aye.
Thank you.
All right, thank you for that. We're going to move on to reports. The first one is, well, first of all, before that, earlier in our earlier meeting, we moved up Dr. Close and Dr. Grover. Are we asking to do that in this meeting, Steve?
If they would like to do so, we could certainly do that.
If the board isn't against that or anybody on the committee, can we move them up and take them now? Any opposition? Seeing none, Dr. Grover, Dr. Close, we're going to turn it over to you, and Dr. Hearn and Dr. Gilad-Dushi, I guess. I know you were all speakers earlier. And Reb, can you do me a favor and send me your phone number later? Can you email it to me? Thank you.
Happy to do so. Yeah. Thank you so much, Chief. And thank you for having us here today. What we're here to chat about is kind of changing the way that we get access to treatment for our patients with opiate use disorder. And obviously I don't need, and some of you already heard this, but obviously I don't need to tell this group about the overdose problem, the opiate problem, the fentanyl problem that our communities are facing. What we're looking at are different solutions. And so I invited Dr. Hearn to chat with this group, and we've been chatting with some of our teammates with EMS about a different way to approach things with our first responders in a way that really puts them on the front of treating patients with opiate use disorder. And just as when a patient has nausea, we treat with Zofran, we're considering when a patient has withdrawal, severe opiate use disorder, we can start the treatment with buprenorphine. That's the medication that we use to treat patients with opiate use disorder. And the studies show that for every 2 patients you give buprenorphine, 1 of those patients has retention in treatment. Obviously, use disorders tend to be chronic diseases, and anything we can do to kind of change the trajectory of what we're on right now is what we're looking at. So with that quick overview, do you have anything?
I was just going to add that when a patient is in treatment with buprenorphine, their risk of dying from an opioid overdose drops by 70%.
So this is obviously where we can make some pretty significant changes for our community. And Dr. Giarducci is here with us as the EMS director for both San Benito and Santa Cruz, because we in the Tri-County area share patients, providers, and our substance use associated problems. There's no reason we can't share the solutions. And so our goal is to move this forward as a Tri-County collaborative. And he's already started it for his 2 counties. So we're really excited in bringing all of us on the same page. So I'll ask Dr. Hearn if he can come on, introduce himself, and then start sharing a presentation to kind of get us all up to date on what they've been doing in Contra Costa, because it's our intent to follow their model.
Excellent. I'm happy to. Thank you so much. Could I be elevated to presenter status? Otherwise, I could just do my song and dance like without slides, but it's probably more
Hold
powerful.
on, Dr. Hearn. I think Steve's doing that right now.
It's all good. I'm happy to.
It's been worked on.
All good. Here I am. Thank you so much.
There you go.
Perfect. I'm here. Thank you so much. So I just want to say that I'm honored to be invited to speak. My name is Gene Hearn. I'm an emergency doc. I'm based out of Highland and Oakland, but I'm also an EMS doc, and I am the medical director for the AMR operation in Contra Costa County, which has about 1 million people. And I'm also the medical director for a couple of fire agencies, Oakland Fire and Berkeley Fire. So we were lucky enough a few years ago to start brainstorming about the opioid crisis and how we are potentially missing patients who either sign out AMA or reached in the field, but never get to a hospital or never get treatment for their opiate use disorder. And we started brainstorming about ways to intervene, and we actually got an initial grant from CDPH to do a project. And so I'm going to spend just about 5 minutes. I think I have 10 slides total, maybe less, to talk about what we did in Contra Costa. And the opportunity is now available actually with a similar grant from CDPH to launch a project in Monterey and the Tri-County area. So I will share my slides and tell you a little bit more. Obviously, for the folks who are in MAC, this is a slight repeat. So I'll try to change my jokes. Sorry. Okay, full screen, great. So this whole process started when one of my colleagues, who is an emergency doc, but also boarded in addiction medicine, started talking to me about patients who we might be missing, and we started brainstorming about sort of if there's an EMS intervention which might actually have some role to play in getting patients buprenorphine. A lot of in the addiction medicine world, there's the sense that if patients with an opiate use disorder see buprenorphine enough times, there's a higher and higher percentage of people actually staying in treatment in the long term. So we got together with the public health folks and the EMS agency folks in Contra Costa and sort of created this program. We realized that the traditional models of care are failing. We have not seen a decline in the number of patients who are dying from overdose. In fact, now there are over 100,000 people a year dying in this country, and we really need to figure out ways to implement sort of a low friction access to buprenorphine for patients who have the symptoms of withdrawal, like they're clearly suffering from their withdrawal symptoms, and we actually have a very safe medicine to give them in buprenorphine, and it also prevents their overdose and dying in the next 36 hours as well. So here's what we started thinking about. We realized that paramedics are really at the scene of this disaster, and in certain circumstances, these patients might be not only amenable to buprenorphine, but actually might get hooked into treatment a little bit sooner. So we sort of started to brainstorm about like optimizing services for patients with an opiate use disorder, and then linking them to ambulatory-based treatments, and then describing what the outcomes were. I started by doing sort of an overall sort of mindscape of like what EMS agencies are actually doing in the US. And this is sort of a little, we tend to think of EMS as a very binary, like you call, we haul scenario. But there's a lot of prevention things we can do before an overdose. And then after the overdose, there are other things we can do that actually might change outcomes. And so we picked the 4 things in orange to do in Contra Costa. The first thing we did was we only had one hospital, which really was dialed in as a bridge site, meaning they had a substance use navigator there. All of the providers were very versed in buprenorphine and how to treat patients with opioid use disorder. And so we actually wrote an opinion piece about an overdose receiving center, the idea being like a trauma center, like a STEMI center. If you could take a patient to a hospital that actually has providers who are knowledgeable, specialized access to clinics, buprenorphine like readily available, maybe those patients might do better. There was no data on trauma centers before the existence of trauma centers, and yet we did it anyway. And then it turns out that trauma centers are the right thing to do. So I think it's really interesting, this idea. So we wrote it up and we actually surprisingly got it accepted. And then we did a naloxone distribution project as well that we literally like stole from San Francisco and thought it was great. And so this is also funded through the state DHCS grant. Then we created this paramedic buprenorphine program. We were not the first in the country. The first in the country was actually in Camden, New Jersey. We were the second. But Camden was really cool. They really were groundbreakers in this. And they actually changed the state law in New Jersey that any patient who got naloxone could be, and were in withdrawal, could be eligible for buprenorphine. Only one agency really has adopted it. But we sort of took that model and added in patients who were in withdrawal for other reasons. So they were just in withdrawal because of abstinence, that sort of thing. So it's a pretty straightforward algorithm. And again, these are street medics. These are not community paramedics or any specialized teams, which also exist throughout the country. But these are just 911 responding medics. And it's a pretty straightforward algorithm. And what we do, this is actually on the California Bridge site. California Bridge is actually funded through the state to help get navigators in hospitals and have emergency departments bridge patients into clinics. So what the paramedics do is they assess for signs and symptoms. They assess for exclusion criteria. There's, if you're under 18 or pregnant or methadone use, those are the big ones. But if you're in withdrawal, and they do what's called an opioid withdrawal scale. And they basically pull up, there's a QR code that the paramedics pull up on their phones, and they actually do an actual calculation of the opioid withdrawal scale. And if the patients are in significant withdrawal, 7 or above, then they are eligible. And so they ask the patients, are you willing? And then if the patients are interested, then the paramedics have to call a opioid protocol provider. We have a team of 7 docs in Contra Costa who take call 24/7, but different places do it differently. So I think San Francisco has a great model where they're gonna use poison control. So the state poison control system is actually going to be their provider approval process. And so with approval, the paramedics will give 16 milligrams buprenorphine, and they can give 8 more if symptoms persist. Then they recommend treatment to a bridge site. And then the secret sauce, we think, is probably the number 4 thing, where we basically had our medics document the care, and then First Watch, which is a program that the EMS agencies use, literally like scans through the data to see which patients are potentially overdoses. And if there's a potential overdose, then the First Watch forwards the email to the substance use navigators with all the relevant data. And then those navigators actually reach out to the patients and see if they can get them into clinics, et cetera. This isn't just for patients who get buprenorphine. These are for any patients who are a potential overdose. And then those substance use navigators are helpful in sort of getting patients into clinics, getting them prescriptions, et cetera. And again, getting them into long-term treatment. So what are our results so far? I think I have 2 more slides. We've had 1,000 overdoses. There were potential patients. We found about 12% of those were actually eligible, meaning they fit the criteria. They had, they were awake enough. They had an opioid use disorder, and about half of those actually got the buprenorphine. So just over 71 in the 2 years we've done it. But what we really care about is long-term engagement. And it turns out about a third of our patients, just over a third, are continuing in care at 30 days, meaning they have a prescription and a clinic appointment. And that's actually pretty amazing based on for being like an at-risk population who is in the field. And remember, these are patients who are, they're miserable, they're in withdrawal, they may be vomiting or have nausea, and they're in pain. And we have actually a relatively safe drug to give them. Buprenorphine, actually, in our 71 cases, we've had 0 cases of bad outcomes, no precipitated withdrawal or anything like that. Sometimes with methadone, if methadone is on board and you give the buprenorphine, you can make the patient a little bit worse. We've had 0 cases of that, and Camden has had 180 patients, and they've also had 0 cases. So it seems like a relatively safe medicine that actually treats the symptoms that they're having, but also gives them the chance to actually get into treatment and get dialed in with the system. So that's all I have for actual slides. I'll stop and see if people have questions.
That'd be for last of Clark.
John, do you have a question? All right, any questions?
Yes, I have a
Justin, go
question.
ahead.
Yep. Actually, the second time I did the presentation. So I had just preface this with, I don't expect any answers from the questions I have, but I do have 4 questions I just want to throw out. The first one would be what the training requirements would be for paramedics. The next question that I have is, would this drug be something that both ALS engine and truck companies have to carry? The next one is this only an ALS transport drug? And then the 4th question is, would all 3 transports agencies in Monterey County have to agree to carry the drug and do the intervention for the program to start?
Totally. Those are great questions. I can answer all of them. So in Contra Costa, we just have the 911 transport agency do it. So AMR in Contra Costa does it. In Alameda County, it's just the transport agency. It's Falk. In San Francisco, it's San Francisco Fire. But they also transport in San Francisco, obviously. So it's ALS transport agencies. If other agencies are amenable to it, it's totally reasonable to do. But that's how it's been sort of focused in those agencies. The training requirements are relatively minimal, in our opinion. We started out with a 4-hour training. We've now honed it down to basically an hour. So it's an hour of really a pretty focused training, and then maybe a little bit more time in terms of each operation, like how it's going to be tracked in the operation. So an extra 15, 20 minutes, maybe with some sign-offs, who knows? But it is a narcotic, so it needs to be tracked that way. And that's it. I think that answered all the questions.
Could I follow up your answers with
Justin.
could I follow up your answers with 2 more questions then? So I understand San Francisco Fire, did they train all their paramedics or just the ambulance side of it? And the reason I ask it is because I don't know from day to day which one of my paramedics are either going to be on an engine or an ambulance. So would I have to train all of my paramedics?
Good question. I believe they're just training their ambulance transporters versus their truck companies. So or engine companies. So I think they're focusing just on the transport side. And it is not a requirement for all agencies to do it. It can be just a focused pilot with a single agency, if that's what you want. And we basically have these Zoom recordings that you can upload to your learning management software, whether it's Ninth Brain or Target Solutions or whatever.
And then you mentioned that it is a narcotic and it would need to be tracked that way. So for like our agency and a couple other agencies that are represented today, we have a physician who basically lets us use his medical license to get our narcotics. So would we have to get approval from him to add that as a narcotic for our agencies?
Correct.
Okay.
Yes.
Thank you. Thank you.
Yeah, no worries. Mr. Robbins.
Yes, a question related to the chief's previous questions there. If I look at this and overall on a macro workload increase is relatively small and there's a small training element. Is that basically it? I'm looking to see if there's any major increase in the overall workload for paramedics in the ambulance.
Yeah, good question. That's absolutely excellent question. It is definitely an additional training if it's 1 hour per medic. It turns out that the number of patients who are eligible is relatively it's not huge. So I think the maximum we've had is 10 or 12 in a single month in Contra Costa. So it's not a huge workflow. What we've found though is we've found that those medics who end up doing it regularly and are champions, actually, it seems like they have an increased level of or a decreased level of burnout and increased resilience. It seems as though there's a sense that 100,000 people are dying every year, and we've run on this to the same house every week for overdoses or whatever, and this feels like this gives them like something to offer when they didn't have a whole lot to offer before. So although there is certainly an outlay, we've certainly found medics who are really excited by this, and that we're very close with the Camden, New Jersey folks because they were the first ones, and their medics come to clinic and actually like hanging out with the addiction docs in clinic and just really get a lot out of it. So that's a really interesting thing.
Thank you.
And if I could add, Dave Gilladucci here with Santa Cruz, San Benito EMS. We've been doing a deep dive on our kind of high utilizers of EMS in Santa Cruz County in particular. And there's a common theme that a lot of these folks access 911 for lots of reasons. And the common theme is that many of them do tend to have an opioid use disorder or some substance abuse disorder. And so I think that there's probably a pretty good return on investment here. In terms of, number one, providing better healthcare for these folks that aren't getting their needs met. And number two, kind of reducing the sort of repeat calls that we see amongst this subpopulation.
Any other questions or comments?
Dr. Hearn, Steve Brooks, CMS agency. According to your flow chart, you have and I believe it was like a medication control physician in the process. What does that entail?
Exactly. So we've at some point, it may not be required, but since this is still sort of in the trial phase, once the medic determines that a patient is eligible, they need to confirm with a provider. And so in Contra Costa, we have a group of docs that take call, but in San Francisco, they're basically their plan, and they're implementing in the next month or two. Their plan is actually to call poison control. And that's obviously a statewide poison control network. And they will get authorization through the poison control folks on call. And so it's interesting. Poison control is actually like funded in under the same agency that the state EMS authority is, which is an odd thing that I didn't recognize or realize until about 6 months ago. So it's sort of their part of their mandate too, as considering this is an overdose. So poison control would be a logical option for you. Alameda County is using their base hospital, but other places are planning on using poison control.
Thank you.
Of course.
Other comments or questions?
Chief Nieto, this is Teresa. I just want to thank Dr. Close, Dr. Grover, Dr. Hearn, and Dr. Gilladucci. I apologize if I have mispronounced your last name, for giving us your time today. This is very valuable information. We are excited about exploring this opportunity. We hope that there are other additional opportunities for regional collaborations. We are interested in regional projects that help us to maximize the use of our resources for the benefit of our patients. So we really thank you for being here today.
I've got a question related to that. For Teresa and Steve, would it be appropriate for the EMCC to endorse this program and encourage its use in Monterey County?
I think it would have to be done at a future meeting where we can agendize it appropriately. We wanted to make sure to give you the information as early as possible. let us continue working on this, and when it is appropriate to bring it, because we have to agendize it accordingly.
Oh, there's one other thing. One other thing I forgot to mention.
And agendize for our presentation at future meeting and possible endorsement.
Teresa, did you get that?
I didn't hear that.
Yes,
very clearly.
Harry made the request that this be brought forward at a future meeting for endorsement.
Will do.
And then finally, Dr. Hearn, I'm going to give you the last word, and then we're going to move on in the agenda.
Absolutely. And thank you so much again for your time. I forgot to also mention that in terms of funding streams, the state of California just announced $6 billion with a B dollars from opioid settlements that will go to municipalities to help deal with the opioid crisis, et cetera. So it's also highly likely that counties will get a large chunk of funding through the state itself, aside from other funding streams that we've already mentioned, CDPH and Bridge. So it's possible that this funding can be even larger.
Dr. Hearn, this is Jesse Allard. I just had a quick question. Is there a, good to see you, by the way. Is there
Hey,
a
Jesse.
Contra Costa champion or EMS agency person you've been working with over there that may be a resource for the 3 Tri-County lenses? Okay.
Absolutely. So so from the AMR side, Troy Vincent is the head of CES. He's the AMR champion. We actually have had the EMS agency medical director, Sinai Kadani, Goldstein before him, and then the public health director, who is Ori Tizvelli, who have all been huge champions for this. So it's been the sort of a 3-legged stool.
Thank you.
Thank you, everyone. Appreciate.
Okay, thank you, everybody. Thank you, Casey, Rab, Jane, and let's see who's left on here. David, thank you.
Thanks. Bye now.
With
Thank
that,
you.
we'll move on now to reports to item number A, Medical Advisory Subcommittee. And Deborah, that looks like you.
Yeah, that's me. There is a written report included in the agenda packet. I would just highlight a couple items from that. One being that we recently executed an agreement with ESO that permits expansion of the health data exchange process to all 4 facilities within the county. And we were working with the individual facilities to the ones that have not implemented. SVMH has already moved forward with that and has had really good feedback on the program. So we're working with the other 3 facilities to bring that into place, hopefully, at those locations. And I would also highlight that we recently completed a human trafficking training for EMS, hospital, and communication center personnel from throughout the county. We had around 40 people attend and really good feedback on that. The EMS providers were able to receive 3 hours of CE credit for their recertifications at no charge. So that's the end of that report.
Thank you, Deborah. Moving on now to the Operations Subcommittee, Kimberly.
The Operations Subcommittee May 11th meeting minutes are included in the agenda packet if anyone has any questions on those.
Thank you, Kimberly. Moving on to Director Rios. Teresa.
Thank you, Chief. The EMS agency updates reported is included in your agenda packets. That, as well as the items on the agenda, show that the EMS agency continues to be very active and productive with many projects in the works and others that are starting to line up. There was one item that I want to highlight, and only because, well, in part because I want to recognize the work that has been done. We have received word from Trump that we will be getting, soon we'll be having access to the STEMI and stroke data through the American Heart Association's Get With the Guidelines. It has been a long process to gain access. During that process, the EMS agency provided clarification regarding the EMS agency's role in the oversight of the STEM and stroke programs. We addressed questions regarding data related to those programs, as well as the protection of data. We look forward to being able to access the data for the use of system improvement. And we thank both CHOMP and SVMH for their participation in these programs.
Thank you, Teresa. Now moving on to MOAC
I'm
activities.
sorry,
Deborah.
I had a quick question. It's Will Hiller from AMR.
Go ahead, Bill.
Regarding the health data exchange with ESO and CHOMP and Natividad more specifically, I was just wondering what the concerns are, what the holdup is for adding the outcome data to the ESO record. The process includes from the EMS side of things, data entry that is required for each one of the patients that we bring into these facilities. And I was just wondering what the holdup is.
There's the HDE is an agenda item coming up. Is that what you're talking about, Will?
Yeah, no, yes, the HDE, and more specifically, why the ESO platform is not being used for stroke STEMI outcome data, including trauma data from the trauma center and from CHOMP.
We are in conversations with the hospitals right now. We have gained access to the data of the platforms that both SVMH and CHOMP uses. They use, and that's the gateway the guidelines. We do know that of the HDE project that is in the works. There was discussion in the MAC meeting about looking into that. Deborah, I think you mentioned that there is looking into whether the STEMI and stroke data can go directly into the ESO platform. So more to come on that.
Will, does that answer your question for now?
For the time being, yeah, thank you so much. Appreciate everybody.
All right, moving on to MOAC activities, Deborah.
There's a written report included in the agenda packet. No significant change in either the COVID-19 or monkeypox related data since the report was drafted. I would just highlight that the EMS agency staff recently participated in the Bronze Pelican exercise at the county's EOC, working within the medical and health branch. We work closely with agencies throughout the county, including all of the hospitals and several long-term care facilities. So it was a good chance to work on some procedures related to evacuations, situation status reporting, and then our communication methods amongst those groups. So unless there are any questions, I don't know what I have.
I don't see any questions. Thank you, Deborah. Moving on now to EMS system performance metrics to communication testing. Kimberly.
The 800 megahertz and ReadyNet drill and testing reports are included in your agenda packet. 800 megahertz and ReadyNet testing remains status quo for the months that were reported. And we continue to report to the hospitals monthly with those results. Are there any questions on the testing?
Harry has his hand up.
I think he still has it up from earlier. Harry, do you have a question?
No.
Oh, your hand is up. Okay.
I don't see Harry's hand, so it's down now. So Harry, so any questions? See none. Kimberly, moving on to contract compliance.
Okay, so the contract compliance report again was included in your agenda packet. Brief summary is that all reportable priorities in all zones met or exceeded 90% compliance April through July, with one exception, which was priority 3 in the green zone for June. This was due to ambulances being diverted from priority 3 calls to higher priority 1 or 2 calls, resulting in more priority 3 calls being late. The MPDS percentages have remained consistent. Are there any questions on the contract compliance report?
Hearing nothing and seeing no hands, we'll move on to the fire-based transport provider report.
Okay, the fire-based transport provider report is included in your agenda packet. We also discussed the reporting frequency of this report, and we'll be making, we made the decision to bring this report quarterly. And does anyone have any questions on the fire provider report?
Seeing no hands and hearing nothing, we'll move on now to old business, the EMCC membership status. Steve?
Yes, to address that, as we saw at the beginning of the meeting, we have a few members who still need to provide their recommendation paperwork to us so we can move this through the board process. And we're working on that, providing reminders so that we can have a full committee membership. And we are, as an agency, we're also working on filling an open vacant position, as well as the alternates for the public representatives. So we're working on that. We've got some recommendations that we're following up, and hopefully soon we will have some more members to bring to this committee.
Great. Any questions for Steve? See no hands or anybody saying anything. We'll now move on to the emergency triage, treatment, and transport. Kim?
After bringing ET3 to EMCC, the EMS agency evaluated the feedback and granted AMR approval to implement ET3 as of August 1st. The EMS agency didn't want to miss an opportunity to benefit patients and the EMS system. We have Ben Hitchcock from AMR here to do a presentation on their data monitoring and how the program is going so far. So I'll turn it over to Ben.
Good morning, everyone. Give me a second to share this. All right, so our ET3 program, this slideshow is going to cover what we're tracking. And also what is involved in our review process for every ET3 case. So for the time being, 100% of our ET3 patients are being audited using the QM module and ESO. At the end of the pilot program duration, we can adjust the percentages based on LMSA guidance. Perhaps we may keep it at 100, we may scale it back. It's just depending on what the results are. The review plan. So with our review plan, we're asking several questions. Are the patients being over triaged, under triaged? This program is very dependent on what is found during initial assessment. So when we review the PCRs, we're asking ourselves, could they have done a more thorough job of the assessment? Or did they perhaps go a little overboard with their assessment and end up taking the patient, excluding them from the program? We also ask if the condition was appropriate for inclusion into the ET3 program. Was there chief complaint or medical condition found post-assessment something that we feel that can be handled via telehealth? Did the use of the ET3 program or telehealth in general cause any delay in patient care? One of the goals of this program is that there is not a significant time on task increase. Once a call is initiated, for example, the ET3 doctors that we use, the doctors group, they will answer the phone, or they'll answer the call, I'm sorry, within 5 minutes. And on average, their pickup time is about 2 minutes nationwide. And then we also review it for the assessment and then any subsequent treatment. We make sure that it adheres to Monterey County EMS policy and protocol. This program is not meant to be a replacement for policy and protocol. It is not meant to circumvent the base hospital system. So we need to make sure that when it's being applied correctly and in with the guidance of the LMSA. Every time an ET3 patient or ET3 is successfully applied, we interview the patient afterward. We have two methods for that. We can we send them an online survey using a combination of Microsoft Forms and Microsoft Power Automate. What's nice about that system is not only if the response is sent back from the patient, it not only comes to AMR CES, but it simultaneously goes to the analysts at the EMSA or at the LMSA. So they're getting the same data we get immediately without any filtration. We also do try to conduct a telephone interview if the patient agrees to that, where we're asking, do they feel like the quality of care they got from the first responders, was it acceptable? Was the telehealth providers' care acceptable? Do they feel like the application of the ET3 program was correct for what was going on with them, what their situation was? We are concerned if they needed to seek additional medical care for the same complaint. So if I'm calling 911 for a complaint and I make use of the ET3 program, and then I end up still having to go to the ED, we want to know about that. We need to see where the shortcoming may have popped up. Was it simple to use? I mean, was there a lot of problem for the end user with the ET3 program? If you have to jump through 50 hoops when you're not feeling good, you're probably not going to be as inclined to use this again. We also asked them what their overall experience was, what their opinion was, and then lastly, we also asked them if there was any possible room for improvement. We want to get input from the public about where we can improve use of the ET3 program, if there's any issues with the platform, if they thought it was right for the county. We have the email survey translated into Spanish as well, because of obviously the large Spanish speaking population we have here. Then we get to the back end. What we monitor is the number of ET3 calls monthly. We monitor the percentage of total system volume, which is expected to be relatively negligible. For example, in August, we had a total of 3 ET3 attempts. Not really a significant impact on the system. We do measure the time on task for each call. The time between the start of the contact with the telehealth provider and how long it took them to answer. We need to make sure that they're still in compliance with that 5-minute timeline. We compare the EMD's reported complaint, the patient's chief complaint, and the EMS provider's primary impression to make sure everything's lining up, that we're not thinking it's one thing and it ends up being something completely different. We do monitor the success rate of the feedback surveys, either telephone or email based. A monthly review of the data obtained through those surveys to make sure that the citizens of the county continue to be happy with the program. We are doing a monthly review of any additional feedback gained, so the patient's suggestions for improvement to the program. We are also monitoring what the telehealth provider's recommended treatment is, and then finally call rate failure. We want to make sure that this is successful more often than not. Does anyone have any questions on the slideshow? I do.
Sorry, thanks, Ben. This is Carla Spencer, the hospital administrator. I do have a few questions, if I may.
Sure.
First off, what is is there a written criteria to actual use ET3, or is this going to be sort of something that you're going to triage every patient, obviously minus the critical ones, right? What's the criteria?
We do have written criteria. I can present it right now if you'd like, or I can send it to you separately, Carla.
Yeah, that would be good. I'm just curious.
Oh, yeah, no.
Separately, so you can send it to me.
Yeah, I will be more than happy to email it to you. It's actually been modified. It was reviewed by Dr. Burley. We made a couple additions to the base criteria to include, for example, anyone who is has an altered level of consciousness does not qualify for the program.
Right. Okay.
Any abdominal pain patient does not qualify for the program.
Okay, Ben, just looking at time, so if you could just send that report over, you can send it over also, if you can send it over to Teresa in case anybody else wants to get a copy of that report.
Not a
Yeah.
problem.
And then a couple more questions. The survey, does that survey go from a third-party vendor, or is that survey coming from you all? The survey that goes out to the patients?
It's coming from us directly. I can actually
Okay.
email you the survey link as well if you'd like to see it.
Okay, good. And then last couple, data visibility. So are we going to be able to review, what avenue will we be able to review the data that comes out of this program? You know, when you talk about all this quality data, is that going to be visible for us to see?
I present a report to the LEMSA monthly. In fact, I submitted August's report already. As far as presentation to various committees, my initial plan was presented to contract compliance. But obviously we have to work that out with Director Rios and.
We were planning on bringing it to the CQI tab committee. So
Okay.
review internally and then also bring it to the CQI tab committee.
Okay. Sharisa, maybe we could talk offline, just who's on that committee. And then what device are you using for telehealth? Is it like a cell phone or?
We actually have multiple options. The system is designed to work on virtually any platform as long as it's a device that is not too old. We have it set up in our PCR Panasonic Toughbooks.
Okay.
We've issued iPhone, I believe they're 11s to every unit, to every field unit, so they can use those. They have the option of using their own personal devices. And then finally, the call can actually be sent to the patient's cell phone if they'd prefer to use their own device.
Okay. And then when did the program go live?
August 1st.
Okay, great. Okay, thanks, Ben. Appreciate it.
No problem. Are there any other questions? Well, thank you for your time.
Thank you, Ben. Moving on now to new business. We already covered item number A. Moving to B. Let's see, that's Steve for the STEMI report.
Yes, so the report is actually regarding the implementation of the AHA Get With The Guidelines database in that registry. And we've been engaged with that with Snows Valley Memorial for quite a while. CHOMP has had some reservations and we've been able to work through those so that CHOMP just needs to get their administration to sign off, and we expect any day now to have access to the registry for CHOMP data. So we'll be able to fully support QI efforts at stroke and STEMI QI.
Great. Any questions for Steve? All right, seeing no hands, not hearing anything, we'll now move on to item number C, EMCC bylaws.
And I'm going to pass that off to Teresa, I believe.
Sure. Thank you, Chief. Thank you, Steve. We are in the process of this year, as part of that 2023 policy and protocol revision, policy 1020, which is the EMS advisory committees, was up for review. As we were conducting the review, we realized that the policy is combining all committees into one thing, but there's also separate bylaws that are approved by the Board of Supervisors. In reviewing the documents, we are noticing some discrepancies, some differences between the last approved bylaws and the EMS policy. To me, it was also, it is not standard as far as I can tell, to have the bylaws approved by the Board of Supervisors and to have a separate policy that addresses the same thing. There's a risk that we run that if we are updating only the policy, then it becomes inconsistent with the actual bylaws. There's also outdated language and other areas, other things that we need to pay attention to. So we wanted to let the committee know. I think that most of the changes will affect MAC and OPS more than EMCC. But in the future, you will see us bring to the committee for endorsement changes to the bylaws.
Thank you, Teresa. Any questions for Teresa? All right, thank you. Moving on to item number D, Fort Hunter Liggett Fire Department, change in service levels. Kimberly?
That's mine actually, Chief. So
Deborah?
we were recently notified by Fort Hunter Liggett that they will be moving to obtaining their medical direction from a military-based medical director. With that comes a change in their scope of practice and a resulting change in their protocols that they'll be using as well. Generally, they're responding on military base, federal government property, so within their jurisdiction to do that. They do, however, participate in the broader EMS system by way of mutual aid and some responses off base down in that area. We think that what they're doing down there is a valuable service to the community and that it's not a lot of resource intensive area, and they are able to help with some responses down there. So they approached us and would like to work out a process by which their paramedics can function under one scope of practice, one set of protocols, and follow those military protocols while responding off base. So that they are not having to function under two separate sets of protocols. So their current agreement with the EMS agency states that they will function under Monterey County EMS protocols while responding. So we are consulted with County Council and are working through with Fort Hunter Liggett and County Council to make necessary modifications to their agreement in order to permit them to work under the one scope of practice and under their new medical director, regardless of where they're responding. So more to come on that in the future. They will also be doing some educational outreach to their co-responders and receiving facilities throughout the county related to their expansion and scope of practices. There'll be some medications, treatments, procedures, that sort of thing that would be unexpected under the current scope of practice for the rest of the EMS responders in the county. So that's all I have at this point. There'll be more to come as we work through that, but I'm happy to answer any questions.
Deborah, I'm not seeing any hands or hearing anybody. With that, we'll move on now to the paramedic training program. Steve?
Yeah, great news. The paramedic program has begun, I believe it's July, and this is the first program under the South County Consortium run at the Public Safety Training Center at MPC in conjunction with MPC. And they've actually got 15 students in the initial class. We just spoke with the program director and he assured us that all the students are doing well. They're coming up to their first midterm. So that'll be a good test of how the learning's going. There's students from local agencies as well as from Santa Clara County who have come to participate in the program. The program staff looks to be very highly qualified. And so it seems to be moving along quite well. And hopefully we'll be having this continue as an excellent local resource.
That's great news for the local agencies, Steve. Thank you for that and the college. Any questions for Steve? All right, with that, we'll turn it over to you again, Steve, for the active shooter exercise at Palm.
Yes, back on the 5th of August, Presidio of Monterey tested their emergency response to an active shooter as an exercise. And outside agencies that were involved were Monterey Police, Monterey Fire, and Pacific Grove PD. And the exercise, unfortunately, engaged non-participant organizations in a way that brought ambulance response as well as a response at CHOMP that altered their normal day-to-day operations, simply, if nothing else, the fact that they went on lockdown. So exercises shouldn't affect the non-participant agencies, shouldn't affect the regular community. So we did an incident review. We've identified some areas for improvement in communication as well as notifications so that incidents like this do not occur in the future. And so we'll be putting together a report on that. We just had a essentially after action meeting with the main participants. It was very well attended, good meeting, and we'll have something available soon.
Any questions for Steve? All right, moving on to the Medical Advisory Subcommittee, Deborah.
Yes, we are bringing this item and seeking endorsement of 2 appointments by the EMS Director to the Medical Advisory Subcommittee. There are biographies for both of the candidates included in the agenda packet in a memo. The first is Rachel Nealand, who would be an alternate for the primary ambulance contractor position. And the second is Christopher Kuzner, who would be an alternate for the authorized air ambulance providers position. So, and again, we are seeking endorsement of those appointments by the EMS Director.
Real quick, can a motion be made to do both together, or does it have to be separate?
You can do them together.
All right, can I get a motion then?
So move, we endorse them.
Harry moves, can I get a second?
I'll second it.
Didn't catch that one?
I'll
Was it
second
Jody?
it.
It
It's
was
Jody.
Good, thank you.
All right, Steve, can we get a roll call?
Yes, give me a moment. Roll call, Will Hiller,
Will Hiller, aye.
Tina Nieto,
Aye.
Sam Klemick,
Aye.
Harry Robbins, Harry,
Aye.
wonderful, thank you. Jody,
Yes.
Nick Greenson,
Aye.
thank you. Carla Spencer,
Aye.
John Anthony,
Aye.
thank you.
That motion passes. Moving on now to the Monterey County Emergency Services Ordinance Revision. Deborah?
Yes, so by way of background for everyone, the EMS system ordinance currently lives in the Monterey County Code of Ordinances in chapter 15.4, and it was last revised in 2009. So since that time, there have been some regulatory changes that have come about that require us to make some subsequent changes to the ordinance. The primary one being AB 389, or also known as Health and Safety Code Section 1797.230. And this requires us to include some language regarding the issues that will be considered when we draft a county contract for emergency ambulance services. At the same time, while we're looking at including those regulatory required changes, we also want to look at updating the current ordinance to reflect what the EMS system currently looks like, the costs associated with running the EMS system, and any future needs that we may have, such as the upcoming RFP process. So we're looking at the ordinance as a whole and looking for potential areas for revision there. So the EMS agency is currently working on a plan and developing a process for updating the ordinance. So our plan is to have completed a draft for public review and comment by the end of October. That will be, as I said, publicized and have ample opportunities for public comment. We also want to give lots of opportunities for stakeholder input and collaboration after that time. So we're looking at things such as holding meetings for interested parties and giving them opportunities to present their questions and any comments that they may have. In the end, our goal is to complete the process by the end of the first quarter of 2023. So there will be more info to come as we kind of further develop and develop that process and the plan.
All right, any questions for Deborah or comments? All right, hearing or seeing nothing, we'll move on now to Steve on AB 361.
Yes, as you see, the staff reports the same information related to AB 361 requirements, allowing this committee to meet remotely under the AB 361 guidance rather than the more stringent Brown Act requirements. So basically, there's a couple findings that this group has to acknowledge being present. First is that there's potential for disease transmission, or whatever cause the state of emergency necessitating people being able to meet remotely. And then second, that this still continues to exist. So if those are the two basic things this group would be looking to find.
Can I get a motion?
Move.
Harry makes the motion. Could I get a second?
I'll second it.
Jody seconded it. Steve, roll call vote, please.
Roll call vote. Will Hiller,
Will Hiller, aye.
Tina Nieto,
Aye.
Sam Clemic,
Aye.
Harry Robbins.
Aye.
Jody Schaefer,
Aye.
Nick Greenson,
Aye, sorry.
that's okay, Carla Spencer,
Aye.
and John Anthony.
Aye.
Thank you.
All right, that motion passes. So it looks like we're going to have a special meeting October 12th at 9 o'clock. Steve, that's correct?
That's what we're proposing, so yes.
Okay, so if you could put that in your calendar, please, just to block it. Moving on now to the announcements. Anybody got announcements for the good of the order? Hearing nothing, our next meeting is going to be November 9th at 10:30 a.m. Information to follow. Steve, anything before we close?
I have nothing other than to thank this group for your active participation, and it's very much appreciated.
And Jeff Horner, if you're still on in the next meeting, Keith Boyd's going to be there. I can't be at the next meeting, so. All right, with that, we're adjourned. Thank you, everybody.
Thank you.